Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thanks, Stephanie. Hi, everybody. Welcome to the August 2019 AHA Team Training Monthly Webinar. This is Chris Hunt, Director of AHA Team Training and a Director here with the Center for Health Innovation at the American Hospital Association in Chicago. Thanks for joining us from around the country and around the world, really, for today's webinar, which is just 6 things what leaders can do to hardwire a culture of safety, improve teamwork, and reduce harm. So I'm going to have a really great webinar, I think, today and have 2 wonderful speakers. Just some rules of engagement before we kick off here. You can listen to the audio for the webinar in 2 different ways. You can listen to it through your phone, and if you do that, you're going to want to mute your computer speakers so you don't get some weird feedback happening. Or you could listen to the webinar through your computer. We recommend listening to your through your computer unless you have unstable internet connection, in which case that's why we have the phone option. We're going to have a Q&A session at the end of the presentation. So the way we like doing this is we like having people chat their questions in throughout the webinar. So you'll see a little box that says chat on your screen, where everybody's typing in where they're from right now. That's where we'd like you to ask questions. If there's something that we could answer, we'll chat back at you right away. But if it's more of a big content question we think that a lot of people would like to hear the answer of, we'll save it for the end and use it during the question and answer session that we'll have at the end of the webinar. If there's any questions that we don't get to, we collect them all and we'll send them to our speakers and have them kind of all answered at one time and then send out the answers. So that's how we like doing this. Just some upcoming AHA team training events. We've got 7 more TeamSTEPPS Master Trainer courses left in 2019. So not many left, but our next one is the 16th and 17th. With our regional training center at Northwell Health, so that's on Long Island in New York. But you could view our course schedule to learn more and register. You can just follow that link that's on the screen right here if you're interested, and it will open up a separate web page, so you can look at it later. If you're coming from the outpatient care world, and this really is anything from primary care to other sorts of medical offices to ambulatory care, we are going to be doing our first TeamSTEPPS Master Training course for outpatient care, and that's going to be with our regional training center at Duke University with the Duke Patient Safety Center, November 6th through 7th in North Carolina. So if you're interested in that, if you're coming from that environment, or if you're just curious about how to utilize TeamSTEPPS differently in the non-hospital environment, that's the course for you. So check it out. Also, if you haven't seen, we're announcing the 2020 AHA Team Training Conference, National Conference. It's going to be in New Orleans, Louisiana, June 3rd through 5th next year. We're really excited about this. We're excited to be able to announce this. We all had, I think, a really wonderful time in San Antonio in June, and so we're looking forward to being in New Orleans next June. We'll be looking for presenters and poster authors very soon. The call for proposals is going to be coming out this fall, so keep an eye open for that. This conference is always built by the people who do the work. It is a very do-it-yourself style conference with a lot of workshops and different sorts of ways to learn how to interact with your peers and get together and work and network. So we think it's a lot of fun. It's based on really anything that can help teams work better when they're in the medical field. So please stay tuned. If you've been there before, we'd love to have you again. And if you've not been there, try to check it out. It should be a good time, and we think it's just going to be in a fantastic location in New Orleans. Some contact information, if there's any need for you to get in touch with us, our website is on the screen there. It's www.aha.org/teamtraining, or you could email us at teamtraining@aha.org or give us a phone call. We try to get back to you within a day, so please hit us up with any questions you have about our programming or about the content itself. If you need help figuring out how to do something, feel free to give us a call. All right, without further ado, I'd like to introduce you to our two presenters that we have today. The first is Colonel Dr. Bonnie Hartstein, who's the director of the Army Medical Department's Quality and Safety Center, and she's also the emergency medicine consultant to the Surgeon General. So we're very looking forward to hearing from her. And then we also have Phyllis Toor, who's the TeamSTEPPS Program Manager and Patient Safety Nurse Consultant with the U.S. Army Medical Command. So I'm excited to hear from Phyllis again. We've known each other for some years, and it's great to get to share all of her knowledge with all of you on this webinar. So I'll be back during Q&A, but I'd like to toss it over right now to Dr. Hartstein.
Thank you so much. Thanks so much, Chris, and thanks everyone for joining us this afternoon. This is really exciting for us to share with you our journey in terms of how we've approached safety and safety culture promotion from a cultural perspective, and really the journey. I know many of you have been on similar paths in your organization. We all kind of share the same ultimate goal, but what I'd like to do is kind of take you on ours here. So I'm on the slide here that shows our hospital system. So this sort of introduces you to who we are. We're the Army Medical Department, and we have about 35 different hospitals, which are actually, many of them, hospital systems. They have multiple small clinics associated with them, so some of them are actually as big as real hospital systems in the cities in which the populations that they serve. So we are spread across the world, and we are actually also broken up, importantly enough, into regional areas where we have what we call command and control. Now, we are a medical organization, but we're also a military organization, which means each of these groups of hospital systems fall under commanders, generals who have oversight of the hospitals and have the ability to issue direct orders to the hospital commanders. It makes our system somewhat unique in terms of accountability and leadership. Even CEOs sometimes don't have as much power, perhaps, as some of our generals wield. So this is a key linchpin to how we sort of put forward some of the programs that we eventually came to when we realized, boy, we have a lot of power, if you will, over our system. Are we exercising it effectively and properly? But just to give you also an idea of our beneficiary population, the entire MHS has about 9 million enrolled beneficiaries. Many get their care in what we call the direct care system, but about 1.5 million are enrolled in actually these hospitals, these clinics that you see across the world. So I'll go to our next slide here where we talk about what we are at the Army Quality and Safety Center. So this is our headquarters level Quality and Safety Center where we oversee and put out the processes and policies that govern quality and safety across the medical departments. We have two parts of our office, the safety side and the quality side. We work closely together, except when we're doing areas like medical malpractice and we want to get an honest look at ourselves. We also have the RCA process, or the root cause analysis process, separate from that, so that we don't kind of we separate and firewall the two sections. But otherwise, we're a highly functioning sort of team here where we try to approach all elements of quality and safety from many different angles. Analytics, TeamSTEPPS has been a long-standing part of our program, and Phyllis will give some background, and that's part of our journey. And then you can see also for quality, we have accreditation, risk management, credentialing and privileging, and the other aspects of a quality program. Going to the next slide here. So we all know that the patient safety movement began many years ago, 10 or more years ago, when we started to realize how dangerous, if you will, our hospitals can be to our patients, and wondering, really, are we doing enough to mitigate that harm and to create safe environments? And of course, the answer was no, so that led the entire country, if not the world, on a journey to try to reduce harm. This isn't new information. These statistics are not new, but it's just to remember where we are. We aren't there yet, but we're always endeavoring to improve. I'm going to ask Phyllis to sort of take us to several years ago when we started the journey towards high reliability and towards improved safety culture that got us to our top 6. But it started with TeamSTEPPS, well known and obviously brings us all together here to talk about. Let me turn the floor over to Phyllis to talk a little bit about the history of TeamSTEPPS in the military and how it started in the Army and how it started as maybe our first endeavor.
Thank you, Colonel Hartstein. Yes, so TeamSTEPPS from its inception has been part of military medicine. We were actually, military medicine was involved in the development of TeamSTEPPS, and most of you are familiar with the, I'd like to call it a culture improvement program, but when we first implemented it in the Army and prior to 2011, TeamSTEPPS was required by Department of Defense for all services, and for the Army, the implementation was by request, and it kind of went something like this. A hospital or a unit had a sentinel event or a serious event, and root cause analysis was completed, and eventually these corrective actions would come forward, and one of the corrective actions would be retraining and team training and bring TeamSTEPPS in. And so for the first few years, the only time TeamSTEPPS was invited into a facility, a hospital, was when there was a corrective action that asked for TeamSTEPPS. So bad issue in a hospital, TeamSTEPPS. By the time I came to Army Medicine and at the Medical Command in 2010, it was difficult to say the word TeamSTEPPS in a room of clinicians and providers without ducking, because you might get something thrown at you because it bad event, TeamSTEPPS, right? So we, at the time, the Surgeon General was very familiar with the program, understood that TeamSTEPPS was a program that contained the basic tools and strategies for high-performing teams to not only support a patient safety culture, but a high reliability culture. And we received the order from the Surgeon General to do an Army-wide TeamSTEPPS culture implementation. You saw the outline for how many facilities we have. What the plan basically was that each hospital, each medical treatment facility, and dental would own their own TeamSTEPPS culture plan, develop their own TeamSTEPPS culture plan. It would be owned and the responsibility of the hospital commander or the hospital director. They'd have an advisory committee, and locally they would be responsible for training, implementation into practice.
This is Colonel Hartstein. I'm not hearing Phyllis, so what I think I'm going to do here is just kind of pick up what we were talking about with TeamSTEPPS. This next slide here, which is our TTPQ, our patient, our culture survey, shows that over the years we have improved in the areas that we measure for TeamSTEPPS, but we still had kind of had a ways to go. But we were showing some movement, and as Phyllis had said, TeamSTEPPS was really, it was rolled out, but it was really at a grassroots level. So the importance here in highlighting TeamSTEPPS is to show how we evolved from the front line to the leadership. So the next slide here it brings us to 2014. So this was a big shakeup, if you will, in military medicine, because we have what we call the MHS review, or the Military Health System Review. This is a congressionally directed review of our entire health system, all services, Army, Air Force, and Navy. And basically, they looked at our quality, safety, and access and said, you really have a good system, but your system could be improved in a number of areas, specifically variance, And there's a lot of variance. Some areas are fantastic. Some areas could use some work. Oh, I'm seeing that there's no audio.
No, we could hear you, Colonel Hartstein. It's just that we've lost Phyllis. We're looking to get her back.
Okay, but I'm seeing a lot of notes here. Okay, so everyone can hear me. Good.
Yeah.
So let me go on with the 2014 review. So we said that they noted that there was a lot of variance, but the other aspect of the problem is that we really weren't measuring ourselves in quality and safety. We thought we had good care, but how could we prove it? This is probably happening many places around around the country, and we have many more measures now than we used to. But at that time, and that had gone back several years of review, not enough measures, too much variance. The next thing that happened is Secretary Woodson, who is the Assistant Secretary of Defense for Health Affairs, said we will become an HRO. So he kind of made this mandate. And, without getting into the details of what an HRO is, we're all familiar with the concept. It requires basically the bottom line is we needed to change our culture. We needed to, so we started training HRO principles. But the operationalization of HRO, it wasn't, we weren't really embracing how do you become an HRO, not just and you don't necessarily do that just by telling people about it. The next thing we did was make some internal changes. These internal changes came about the development of my office. It came out from under like a clinical operations section and became its own directorate. We developed what we call we started actually measuring ourselves and looking at our quality measures. But the quality measures that we chose, they were also sort of external, and they wound up being things that we could measure, which may sound funny, but in our system because we didn't have a lot of measurement in place, we had to go back to our own electronic medical record and our data and say, what is it that we can pull down and measure? And they wound up being either bad safety events like wrong site surgery and unintentionally retained foreign objects, and then other like HEDIS measures, low back pain imaging, children with pharyngitis, making sure that we were doing the right pharyngeal swabs and before giving antibiotics, and diabetes screens. So we endeavored to measure ourselves as a measure of quality, which is not a bad way to measure quality, but the quality and safety, the quality measures, the HEDIS measures, and the safety measures, which we would call the wrong site surgery and IRFOs, those kind of lumped together. So and we were definitely measuring, but we weren't necessarily giving people the tools to do the low back pain and the children with pharyngitis. But in terms of wrong site surgeries and IRFA, we had TeamSTEPPS is basically what we had, which is an excellent approach. But how do we combine it all together? We know that learning from the airline industry that the way to really get towards better outcomes is to, they did it with checklists and crew resource management, which when you translate that into medical terms, turns into standardized work and communications. And so we also had the ability to look at our own errors. I'm going to go to this slide right here. So what we did was one of the other internal changes that we made was to develop what we called a reset team, which was a root cause analysis engagement team, and they went to locations where there were actual sentinel events and did help them with the RCA. So from this way, with all of our organizations across the world, we were able to look at a Pareto chart of our top problems. So we knew we were improving in our metrics, and we knew we were still making errors. So how could we learn from what we were finding were the highest problems, the biggest problems across our organization, to operationalize or lead change in those areas? So you see in red in this slide that we found leadership. I said, oh, hey, we're a military organization and leaders are in charge, and all that is true, but what we were failing to do was to leverage leadership to influence the culture of safety. Physician leaders did not empower their staff to voice concerns. Physician leaders did not discuss risk mitigation plans. We found this again and again, that the leaders weren't we weren't giving them the tools they needed to influence their staff to actually exercise policies. We had plenty of policies and plenty of procedures, but they weren't necessarily in place. I'm going to go back 2 slides here to show that we all know that leadership here in the Joint Commission, in Jason and Loeb, this is fundamental to becoming a high reliability, is to leverage that leadership. Hey, we're a military organization. What can we do to empower our leaders? We re-looked at our office. What were we doing in the Quality and Safety Center, a headquarters element, 35, 40 people, stationed, working out of an office in San Antonio in charge of a worldwide oversight of a worldwide organization? How could we do something to actually influence change? So we thought hard. We had a very strong leader at the time, General Clark, who was very interested in making things as simple as possible. He said, make it dirt simple. He was from Tennessee, and he was very entertaining and very brilliant individual. He said, what do you do at the headquarters level to get these numbers down? These wrong-site surgeries, these IRFOs, they're still happening. So we thought we need to understand and prioritize our areas of patient risk and simplify and standardize those processes. What can we do to get to that checklist and the standardized work? So in the green is what we were going to do at the headquarters level. The blue, those were the areas across the world that the regions that were grouped, the grouped hospital systems. We figured the commanders of the regions could help us to ensure that they routinizes and assess compliance. So we were going to put out the program, and at the region, they were going to hold people accountable. And the black, everyone was eventually going to get to this high reliability, zero harm. So this was our plan going forward. Okay, but what were we going to do in the green? What were the actions that we were going to actually put in place? So that brought us to the top 6. So this is an interesting story. We had then developed a plan. We were going to teach. We have periodic teaching opportunities where we bring together hospital leaders and we give a week-long training. And we had, at this point, grouped a variety of different practices that we knew were important and had lectures, a week-long lecture series planned to train everyone on these processes. And then, as luck would have it, it was scheduled for the end of January. A big snowstorm hit. The snowstorm hit and wiped out our training. The entire thing got canceled. So we were left back in the room with General Clark with all these slides and all these briefings and no way to put them out across the world. And he said, this is what we're going to do. This is where we're going to operate as an Army. We're going to put out what we call an op org, which is a directive, an operations order. They use it in battle. We're going to leverage it for the medical department. And what we're going to do is package all the things you were going to teach in that great week-long course, and we're going to put it into one single document and have everyone do it. These had already been pushed out. None of the top 6 that we're going to show you are new. They're not new in industry. We didn't come up with them ourselves. They're not patented. All they are is a packaging of a program that we put out because of the snowstorm to all the senior leaders worldwide and all the hospital commanders in a like 4-page document with video links and I'm going to go very quickly high level, and then Phyllis is going to dive into each practice and help you understand, sort of the nuts and bolts behind them. So what is the top 6? The top 6 were 6 safety practices, 6 practices that we thought would get at the problems we saw in our organization, those high-level problems, leaders not staying engaged, people not having a culture of safety, people not empowered to speak up, and lack of standardized practices. We grouped these into three kind of buckets. One was driven by leaders. The second bucket was those driven by the frontline staff. And then the high-risk areas were just the universal protocol we were going to use across every area. Again, not something necessarily even new. And each of these had already been put out in a different forum. But here we were packaging them as one entity. The next slide here that shows just a little description of the hospital shows kind of the levels in which these were going to occur. The unit-based huddles being a tiered huddle happening before the leader safety brief, and Phyllis will go into details. So that the team is meeting on the wards, they're finding issues, they're briefing the leader. There's an opportunity for the leader to have all this information roll up to the leader. Every single day we created standards. If you need to do this, you need to do it on this type of ward, you need to do it, every leader has to do it 5 days a week. We introduced safety walk rounds or safety leadership rounds. And then the other areas using universal protocol, that was already instituted, but we included it in our top 6 to remind everyone. SBAR is a communication tool, a very important way to communicate critical information, and then instituting the surgical briefs and debriefs before every single OR case. So this is our top 6, and like I said, it may not seem super avant-garde or crazy groundbreaking. I think the power in it was that the way that we grouped it. Here's just another depiction of the top 6 showing the tiered huddles and the use of SBAR in terms of the communication bundle, and then the operating room bundle. So I've seen some questions come up that said, you know, how could an organization that didn't have the leadership structure do this? Well, I still think it can be sold as a package deal, and that people can still, you know, because of the simplicity of it and its grouping into a single package, I think that was the strength. What I'm going to do now is turn the floor over to Phyllis to talk us through in detail the way that we taught each of these different elements and the details we provided to leaders to operationalize them. Phyllis, I hope you're back on.
I'm on. Can you hear me, ma'am?
I sure can. Thanks.
Super. Okay. I apologize for that. I don't know what happened. And watching the chat, it's been pretty interesting to watch as Colonel Hartstein was talking. I noticed that, you know, there was several comments about this doesn't work unless it comes from the top down. And what I wanted to get across in that second slide where you could see the TTPQ data, which is the TeamSTEPPS Teamwork Perceptions Questionnaire data, those years where we worked on improving the teamwork culture were truly a frontline effort. I feel it was a grassroots effort because although we had this operations order from our Surgeon General and commanders were told this is your program, it really was left up to the frontline staff to figure out how to make this work. And they did. And they were able to create improvement. But we could only get so far. So for me, the excitement of this top 6 bundle is that it's all rooted in TeamSTEPPS. If you guys are familiar with this, and if it's not TeamSTEPPS and another teamwork program, the strategies are the same. They're just called something different. But this top 6 clearly lays out the responsibility of the CEO or the Army commander in implementing these 6 simple things, 6 simple actions with a high-performing impact. And the first one is the Leader Daily Safety Brief. Lots of information in the literature on this. What we did was we asked our leaders to conduct a daily safety brief, bringing in all departmental leaders to participate, bringing information from the units that come from the unit safety, the unit daily huddles, and we'll talk about those in a minute. Each department lead attends, all C-suite leadership is in attendance, and hot issues are brought up to leadership. I've been a nurse for 35 years. The first 20 years or so, 25 years, when I was in a unit and there was a problem, and that nursing supervisor would come around to pick up those problems and then bring them to the first morning report, you hoped and prayed that 6-8 hours from now something might be settled and you might have an answer. This brings issues in the units directly to the commander and the other chiefs so that they have a high visibility on these situations, past and present, 24 hours, any hot topics that they can be addressed. It's amazing to watch this in action. This is not morning report. You don't go over specific patients, and it takes no more than 15 or 20 minutes, even in a large hospital system. I have the opportunity again and again to visit our hospitals, and every time I do, I ask to go and watch their leadership daily safety brief. Next slide. So the why use this practice? It just brings the needs of the patient to leadership front and center. The leadership, the frontline staff and middle management gain a shared mental model. Everyone is connected to important safety issues and decisions and have a part in the decision on how to mitigate. Briefly, I'll give you an example of something I witnessed where I was at one of our larger hospitals, and they were doing their morning leader daily safety brief. Most of the teams were green or amber, and one team, the inpatient psych unit, reported red. They reported red. They were full. They had done an assessment of their patients. They didn't see anyone who could be discharged that day. At the moment, ER was not on bypass. EMS was not on bypass. As soon as this was reported, the commander looked at the chief for inpatient services, said at the end of the meeting, I need you to go to that unit. The chief and the chief of that unit both went to the inpatient psych, requested a huddle with the nurses, with the charge nurse and with the nurse, any nurse that was available. They discussed the issues. They came up with a plan. The staff was highly on board and ready to implement and do whatever they had to do to get that plan implemented. Obviously, ED went on bypass, EMS went on bypass, other hospitals were alerted, and staff was completely on board with the plan because they were part of the solution. And the follow-up the next day, that evening and the next day, and the issues that are identified at that meeting. The second one, and these are not in order of importance by any means, is the leadership safety round. Now, again, anybody who's been in healthcare for a while or worked in facilities for a while, for at least the first 20, 25 years of my practice, boots on the ground, a leadership safety or leadership rounding used to look like leaders walking through the unit, doing the parade salute or the parade wave, and maybe stopping to say one or two things. These safety rounds are focused. These safety rounds, they have very specific questions that are going to be asked. The questions are based on the issues that come out of the leader daily safety briefing. They come out of the patient safety reports. They come out of other tracers. They are assigned. They're prepared and open questions. They take advantage of teachable moments and pre-scheduled. And we ask our leaders to monitor the progress of these items, actually track them on a tracker and with data taken, and then also to feed this back to the staff, the outcomes and some of the resolution. I'm sorry. So why use this practice? Leaders, the simple act of leaders communicating with the frontline staff, asking questions like, what issues in this unit keep you awake at night? Or if you had one thing you'd like to fix, what could it be? This shows senior leadership engagement at a very high level. There's collaboration with safety practices between leadership and staff, helping to identify frontline concerns, and it definitely fosters the culture of safety that we're looking to foster in the Army. Now, sorry, I neglected to mention the measures of success for the number one, but for number two, our measures of success are very simple, and they're self-reported by the commanders. So, in other words, for this measure of success, the number of safety rounds per month, we're asking green to be 4 or more, amber 2 to 3, and red 0 to 1, obviously. And it's amazing when we do our, we have a quarterly meeting, pretty regular quarterly meeting where our commanders meet with the regional commanders, meet with the deputy for OTSG, where they won't all say they're green. They're very honest in how they're doing, if they're amber, and why they're amber, and what some of the pitfalls are, and then there's some discussion on how we can help them overcome some of that. And then another very basic, this is all about getting back to basics, and these are all, each one of these so far have hit TeamSTEPPS strategies. But the number 3 is unit-based huddles, and if you're a TeamSTEPPS aficionado, you would call this a brief, but it's really about the action. And this is a critical teamwork action that brings together individual high performers with the goal of developing high-performing teams. The huddle for planning or briefs are the most basic team communication action that we can take to help with the development of high-performing teams. And you can see in this pictorial here on this that the unit-based huddle should occur before the leadership daily safety brief, and that information from the huddle then feeds right into the safety brief, which occurs shortly after the unit-based huddle. And then any issues that are hot and need to be further investigated become questions in the safety leader rounds. So the communication is ongoing and almost a closed loop, because then the information from the safety brief and the leadership rounds should come back to staff either in the unit-based huddles or in another forum. This is just an example of a checklist for the unit-based huddles. Unit-based huddles, they have to be short. They are not a staff meeting. It's not patient report or handoff. That's a separate meeting. That's a separate interaction. There are other examples of unit-based huddle checklists. There's one in the TeamSTEPPS handbook, and those are online and open in the public domain. And really, unit-based huddles or briefing checklists should be customized to each unit, and you'll see another example of one later that we use for our OR. So again, obviously this practice is important because it provides a shared mental model for all team members to be able to focus on the goals of the day and the needs of the patient. It provides situational awareness, designating team roles and responsibilities. It's critical. The OR, the team unit-based huddles, have shown evidence-based to reduce in an OR climate, to reduce sepsis by 50% post-op. By implementing unit-based huddles or briefs, 50% reduction in ED observed errors, over 50% reduction in ICU stay, and a 55% reduction in OB adverse outcomes, just by the entire team knowing the plan, knowing their role, and knowing the goals. Again, this is the most fundamental teamwork action. And then one of my favorites, the old SBAR. SBAR has been around before even the development of TeamSTEPPS. Joint Commission was encouraging the use of a tool like SBAR for years prior to, again, TeamSTEPPS development. We were touting and encouraging the use of SBAR in the Army since 2008 when we were implementing TeamSTEPPS. And it's pretty interesting that it should have to show up again in this top 6. But the issue with SBAR and this particular goal has been the most confusing goal for our teams to implement. So that tells us that it probably was one of the best choices in putting in our top 6. Folks were using SBAR in a very elongated way to hand off patients. Folks were using SBAR only on the phone. Folks were using SBAR in different situations that they had predetermined. Its simple purpose is a standardized technique to communicate critical information.
Sounds like we lost Phyllis again.
Okay.
Colonel Hartstein, you want to continue on SBAR?
Yeah, I sure will. So SBAR, I think the biggest question that Phyllis was alluding to in terms of how to get SBAR right was there was a bit of a confusion whether SBAR should be used as like a handoff tool in terms of during a shift change or a tool for complex patients. And truthfully, SBAR was developed, as many of you may know, for communication on submarines. So the idea of SBAR is really just to relay a very critical piece of information, a kind of a discrete piece of information, and to kind of get to the point and to empower the person you're telling to take action. That's why it ends with recommend and request. So we went back and we also, made sure that people understood that. Phyllis, are you back now?
I am, and you're spot on, Colonel Hartstein. Thank you so much. And I think, again, going back to what you were saying and the confusion that we had sentinel events where when we did our RCAs, we felt that a simple SBAR could have prevented or at least moved the Swiss cheese to help prevent the event. So going back to the basics, this was critical for us. In hardwiring this, it's important for us to know that a simple movement of one element of the process can change everything. And I'll explain one of my early experiences in training in the Army with TeamSTEPPS. When I would do our master trainer courses and I would get to SBAR, I would always ask everyone in the room, who uses SBAR? And in this one particular room, it was silent. And finally, a nurse put up her hand. And she said, we used to, and it worked really great, but we don't anymore. The nurses liked it, the docs liked it, but we don't anymore. And so I said, well, that's great. And so tell me a little more about why we don't do this anymore. And her answer was, the sticky pads are gone. The sticky pads are gone. Well, apparently on investigation, at one point in this facility, at this hospital, they had little sticky pads with SBAR. And before bringing an issue to a provider or to someone else or calling somebody, they would work out and write out their SBAR on a piece of paper. And simply by those pieces of paper disappearing, the use of the SBAR disappeared. So we keep this in mind when we try to hardwire whatever we're trying to hardwire, and SBAR in particular. But, yep. And the measures of success are really from the leader, safety rounding, and tracers. So again, it's an internal assessment. Green is that they're using it consistently in all wards, and an amber and majority and SBAR used infrequently. And it's interesting, again, when we do our quarterly check-ins, that folks are reporting themselves red and amber, and being very honest about this when leadership is involved. So the surgical brief and debrief, surgical brief and debrief, as we had said before, all of our units are required to do briefs or huddles, whatever you want to call them. But because of the high acuity in the OR and some of the data that we've had with implementing briefs and debriefs, we have the decision to focus on briefs and debriefs is related to some of the gains that we've seen and wanting to even add to these gains. And so the OR briefs occur before the patient ever comes in the room. It ensures that all team members are informed about the surgery, any issues. I'll show you our checklist in a moment for these, which is a brief checklist that looks a little different than the checklist that we use for the other units. They mitigate any issues ahead of time and empower the team to speak up for safety concerns. And that one item there is one of our major focuses on this implementation. So this is kind of what it looks like. The brief process conducted before the start of the case. The entire team is there. So the surgeon, if there's a resident, the nurse, the tech, anesthesia. The brief doesn't happen if someone's not there. And if the brief doesn't happen, the OR cases will be delayed. And then if a doc has 3 cases, the doc will brief all 3 at the same time. We use a checklist. It's systematic. And again, for all of the teams to understand what the goals are for the day. The debrief process occurs at the conclusion of the case before the team leaves the OR. typically, in cases where there's skin closure involved, it's while the skin is being closed. It's a low acuity time of the case. We identify case delays, equipment issues, safety issues, anything unexpected, recognize good teamwork, anything that could be improved on, and we have a debrief checklist. And we also collect this data in an electronic computer-based data collection tool that's a SharePoint-based, so that we can use our data to identify issues and trends. So it's more of a proactive indication of where some of our issues as a group may be. So for the operating room bundle, just the visual here, the surgical brief is all of the team pre-procedure, and the surgical checklist, I know you can't see it on this one, but we have it on the next slide. During the case, the timeout, that's another team activity that may not be separate in TeamSTEPPS, but it's certainly all of the elements of that activity is rated in TeamSTEPPS, and then the debrief as I just described it. This is our current brief and debrief checklist. I'll just bring attention to a couple of things on this that have been added based on either our issues that we've seen in our ORs or patient safety reports or other data. On the surgeon's role to ask the team to speak up at any time for safety issues, that was a recommendation of a surgeon who felt that the team that he or she has been with were not empowered fully. So for surgeons to say that, if a surgeon says that to a team, I want you to speak up, that's giving permission. Again, one of the weaknesses that we have is teams don't feel encouraged or empowered to speak up. So and we put that on the checklist. And then critical moments. This one is not on every checklist that you will find, but critical moments are those moments where we shouldn't be talking, there shouldn't be a lot of movement in the room. So identify those critical moments before the case so that everyone is on board, has situational awareness, and is providing mutual support. Those are critical elements on our checklist. Now, the debrief, on the debrief checklist, if you see, we've switched the roles and we get the technician or the most junior person in the room to give their recommendations for improvement first, and that's purposeful. Because if a more senior person in the room says, I think everything went great, then the junior folks in the room may not feel encouraged or empowered to speak up. And then on this checklist, we added our middle section, and this was really wanting to give situational awareness to the entire team of what the paper form of the timeout in the Army looks like for a surgical case. And all of those elements there are not abbreviated. That's our full timeout checklist. And it's a reminder also that everyone stops, everyone pays attention. So that's new for us, and we're hoping to improve our timeouts by having more visualization and situational awareness. There's also a reminder on there for the team to do a quick huddle before the case if anything has changed or if anyone has information that the entire team needs. So, and then that brings us to our final elements in the top 6, the universal protocol. Of course, this is the final check. This is one more check. Universal protocol is a very redundant list of checks that we're ensuring that we've got the right patient, the right surgery, the right site, and following Joint Commission standards. We've put this on here as our number 6, and our measure for this, of course, is 100%, where none of the other measures are at 100%. It's green. We didn't even want to really validate anything less than a green 100%. So, and oops. Wanted to add this so that you guys had a little bit of visibility on what our hospital compliance tool looks like. This is what the facilities fill out and send to their regions, and the regions fill out and send to the general self-assessment. Very simple. They do this online. We have one also. We don't forget our dental folks. We have a large dental component. and we hold them accountable to the same standards that we hold our hospital folks to, and so that we're above and beyond what most of the civilian dental requirements are. When we kicked off the operations order for the top 6, we gave our commanders and access to these videos. These are some of the videos on what right looks like. I think there's even a VA video in here for our VA folks that are out there. But it's what right looks like, and we required that the C-suite commanders and deputies all watch these, and that was part of their first reporting requirement. Another tracker. Colonel Hartstein, did I miss anything? Is there anything that you'd like to add?
Oh, no, Phyllis, you did a great job. I know we just have about 9 minutes left, so I think we want to let people ask questions, but fantastic job, great being partners with you. We're in different parts of the country right now, so we're sort of doing our best to tag team. So let me ask the HA people, folks, to let us know what questions we can answer. Over.
Oh, thank you both very much for that. That was great. It was really wonderful to have everything broken down in very practical, 6 specific things that you're doing. So thank you for the webinar. We do have some questions. We have some very nitty-gritty questions about each of the 6 areas that we might cover first, just to kind of get some of those answered. And then if we have time, there are some that are a little bit more, I would say, on a philosophical nature. So that's how I'll try to organize this, if that's okay with both of you.
Sounds great.
All right, sounds good. So I'll ask some questions about each of the 6, or as many of the 6 as possible here. One of the questions that came up is, when you're doing either the leadership briefing or even in some of the unit-based huddles or any of these elements, not all of the problems can be solved immediately. You know, this is really a time, I think, in these briefs and huddles for people to bring up questions. So how do you manage the issues that are ongoing, that maybe can't be answered in a second, or that might be something a little bit larger like staffing or something along those lines?
Great question. We did provide trackers and have asked actually leadership elements to keep track of what we call like parking lot issues or things that are going to take a little bit more time. The most important thing literature shows is that you actually communicate back to the people that you're trying either to take action or you're working on, or you have, parking lotted with the idea of coming back to it later. And even the metrics that Phyllis showed, we've been maturing so that some of our metrics now for leadership for the leadership huddles are to track completion of outstanding items. So it's not just to gather them, but to actually, if you're going to put them in a tracker, to show progress towards working through them over time. Any other comments, Phyllis?
No, that's perfect. Thanks, Colonel Hartstein.
Do you think that, so then is somebody responsible, then is it an individual who owns that tracker that's responsible then to maybe bring that information up to the next level, or somebody that wasn't there? Is it somebody's specific duty to do that?
Yeah, I think the trackers involve making someone the point of contact and then having a path towards completion of an issue. Like, obviously, if there's staffing issues on the ward that day, that needs to be handled immediately. If it's long-term staffing issues or problems with infrastructure, that's going to take longer. So at least putting someone in charge, but the leadership oversight of that tracker and the commitment to at least follow things through the completion or to communicate back why maybe something can't happen within the current constraints of the organization, that's the important tail end of this endeavor. Over.
Do you use formalized sets of questions for the SLR or the unit-based huddles or any of these elements?
Yeah, the unit-based huddles has a checklist, if you will, the leadership walk-arounds. We didn't give people scripts, but the teams were encouraged to come up with their specific questions that they were going to ask on the wards when they, to go with a concept in mind or an idea in mind. And then there were the videos that gave some examples. Phyllis, did you want to have any additional information about that?
Sorry, I was reading. I have to admit I was reading some of the questions, so I missed the end.
Oh, it was just about whether or not we gave anyone scripting to. I said for the unit-based huddles there was a checklist, and then for the leadership rounds there wasn't so much specific scripting for that. But
they developed their own scripting for that. Yes, absolutely. For the leadership rounds, they have to develop their own scripting because it is really specific to what their issues are. And again, issues coming out of the leadership safety brief and the coming from the unit-based huddles. So the leadership rounds need to be focused on what the critical issues of that facility are.
Got it. Skipping over a little bit to, this is a question that I've gotten before and heard a lot myself. When you're doing the surgical debrief, if it's in something like obstetrics where the patient is awake, do you still do that debrief during close or when the patient's awake and can hear the debrief?
I can take that one. Yeah. Yeah, that's one of those cases where the team has to decide what the best course of action is. If it's a debrief where if the patient's awake, more than likely any issue that happened, the patient is aware of, and you can actually involve the patient in the debrief. You could ask the patient, in your opinion, what went right, what could we have done better? And then anything that might be risk issue, the team should speak about outside. There are facilities where the chief of OB has decided all of the OB teams will be debriefing outside of the patient room. It gets a little harder because once people scatter outside the room, getting them together is an issue. But OB, this has been, the collection of debrief data in the OB has been voluntary, and they're all asking us for the data collection tool. So it's something that they want, and it's something that they see value in. And again, whether they do it in front of the patient or not, it's just keeping that team together.
When you're speaking of being in the middle of surgery, what do you do if a staff member is added to the team during surgery and they've not been present for that pre-surgical brief? How do you get that person up to speed on what's going on? Is there something special you're doing?
You use your tools. You use the handoff tool to hand off the information that was shared in the morning brief. So a quick huddle with the person that you're relieving to include the critical elements, whether it's just a lunch break, because sometimes it is just a lunch break, or if it's somebody has to leave for the day. The thing that we avoid and we look to avoid is that type of a handoff during a critical moment. And that's why knowing what those critical moments are so important to the safety of the patient and the team.
Thanks. All right, I think we have time for one more here. I'll jump to one of these that are a little less on the practical nature and a little bit more on the philosophical nature. Somebody was asking about how do you go about implementing this when leading from the middle? I think the military, you've had that coming down from above that this is something we're going to do. But what do you recommend for somebody who has a strong interest in improvement and really wants to get their senior leadership to buy in, and then also get some of the other people they're working with, their peers, to support them and take ownership of this?
That is a good question. I think, go ahead, Phil.
I was going to say, even though in the Army we did have our operations order from our Surgeon General back in 2011, this was honestly led from the middle for many years. This is the first time we really have someone like Colonel Hartstein and the other leaders in place that are giving us the true leadership buy-in and ensuring that the commanders are on board. So when we were leading from the middle, and even though I'm a coach from MedCom, when we were leading from the middle, we only control what we can control. We make recommendations to our leaders, whether they want to take it or not, but we can control what we're going to control. So if I was a nurse manager in a unit and I wanted to implement TeamSTEPPS and no one else in my hospital was implementing it, I could take TeamSTEPPS or the bits and pieces of the top 6 and one at a time implement with my team members to the best of our ability and empower the team to use these tools to the best of their ability. So control what you can control. Have a plan. Include your team in the development of that plan. Make sure the team understands the plan and keep checking back and celebrate your small wins. Every win you have needs to be celebrated.
I think that's a great way to end this webinar. We have other questions, and we'll make sure to share them. A lot of people had some great questions coming in, especially here towards the end, so we'll make sure to share them with you. But I'd like to thank you both. Phyllis, thank you for everything. Colonel Hartstein, thank you very much for presenting. Thank you for your service. And to everybody that was on this webinar, we'd really like to thank you for joining us this month.
Thanks for the opportunity.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.